Good morning.
Glad to know somebody's out there.
Good morning. Good morning.
Well, thanks everybody for joining the spring meeting here in person, as well as those of you who are at home or other locations remotely. This is the Barlogie-Salmon Myeloma Committee, as you well know, and we have over here on my left Antje Horing, who's our main statistician, and on my right is Christine Yee, who's our vice chair, and we'll review where things stand with current ongoing studies, as well as some updates on studies that are far enough in development that we'll be able to give you more or less final overviews of the protocols, and hopefully then we'll have a little bit of time for discussion if any other topics come up. And I'm going to pass the microphone here over to Dr. Yee to help us lead things off.
Thank you, Dr. Lansky. And thank you, everyone, for being here so early to attend the meeting. All right, so we'll get started. So we'll start with a few ongoing studies with S1803, 2005, and also ECOG studies. We'll invite Dr. Chopra. I think he is actually online, who will present the updates for this study S1803.
Thank you, Dr. Yee. Can you hear me?
Yes, we can.
Perfect. So first of all, I'm very sorry I couldn't be there in person. I wish I was there with you all. So thank you for giving me this opportunity on behalf of the entire SWOG S1803. So SWOG S1803, or the DRAMATIC trial, as you know, is a phase 3 randomized trial investigating single agent lenalidomide versus lenalidomide plus subcutaneous daratumumab as maintenance therapy following autologous transplant. Next slide, please. I'm guessing you're running the slides, or would you like me to share? Perfect. So briefly, adult newly diagnosed myeloma patients up to 75 years of age who are within 18 months of starting induction and without progression at any time since diagnosis are eligible for this trial. There are 3 registration steps. Step 1 may be before or after autologous transplant. And the trial has 2 randomizations, which are referred to as step 2 and step 3 registrations. Patients undergo first randomization to len or len with daratumumab within 180 days from autologous transplant. MRD is assessed using next generation sequencing on the clonoSEQ platform prior to the start of maintenance and then annually. And then randomized treatment is to continue for 2 years, at which point patients who are MRD negative at less than 10⁻⁻⁶ undergo a second randomization or step 3 registration, and they either continue maintenance on their assigned arm or they discontinue maintenance therapy. Next slide, please. So the primary objective of the trial is to compare overall survival between lenalidomide and daratumumab as the experimental arm and lenalidomide single agent as the control arm. The objective of second randomization is to compare overall survival of MRD negative patients who continue maintenance on each arm versus those who discontinue. Next slide, please. And here's a timeline of the important milestones for the trial. The first patient was enrolled in August 2019. Previously, a total of 1,100 patients were to be enrolled on the trial. If you can move on to the next slide, please. So at end of March, that accrual goal was met, and the study was temporarily closed to accrual on March 29. We have a revision 7, which involves the use of HydroShift assay to evaluate treatment response more accurately in patients with IgG kappa myeloma who are in very good partial response, and that was activated last month. And lastly, a revision 8, which mainly involves a change in the study sample size, is in review with the NCI. So the accrual, as you can see here, has exceeded the projections. Moving to the next slide, please. And there's another way to look at the accrual trends on a monthly basis. And here's a list of the top 15 enrolling sites with more than 16 patients enrolled. So in revision 8, there are a couple of things we worked on. One is the MRD determination or adjudication based on the clonoSEQ report. And we have clarified as to what constitutes MRD negativity. The protocol wasn't very clear previously, and there was some contradiction in the MRD negative and positive statements. Next couple of keystrokes. So we have clarified this now, and MRD negativity is defined as, you can, yeah, keep moving, please. So MRD negativity is defined as less than 1 residual clonal cell per million cells, and we could have MRD negativity even if residual sequences are detected, as long as we have less than 1 in 10⁶, or a million nucleated cells. Next slide. So the other major change in revision 8 will be the sample size, which will be increased to 1,421 step 1 registered patients. Next keystroke. So we have a total of 1,214 eligible patients randomized. And this will be done in order to account for a smaller than expected number of patients. So this is to account for the smaller than expected number of patients who have been eligible for second randomization. The objective of second randomization is quite important, as we all know, which is the survival of patients who stop versus those who continue if they are MRD negative. So with this revision, we would have sufficient power to find a difference in survival if there are 91 patients in the len arm and 152 patients in the dara plus len arm. There is a mistake here on this slide. We actually have 90 patients second randomized out of 330 patients reaching 24 months of maintenance. So we have 330 patients who have had 24 months of maintenance, not 165 as shown here. So a few more points I want to bring up. We do need the documentation for drug destruction for the expired investigational product from sites as soon as possible. And we'll be reaching out to the sites individually also. And a couple of points regarding step 3 or the second randomization. So 24 hours urine protein electrophoresis is very much needed at 24 months before step 3 registration. And in fact, MRD results will only be released after the 24-hour UPEP is completed. Local MRD results should not be used for step 3 randomization. We can only use the clonoSEQ results for MRD assessment and randomization if the patient is eligible. And lastly, if the patient is randomized to stop treatment, then we should please follow the protocol and stop treatment. And I think that's all I had to cover. Thank you very much. We have an acknowledgement slide after this. I'm happy to take any questions.
Thank you, Dr. Chabra. For the audience, either in person or online, if you have any questions, I think it would be a good time for us to discuss because the protocol is on hold temporarily. Hopefully we can resume enrollment very soon. If you have any questions from any of the sites, feel free to raise the questions.
I just want to make 2 quick comments. First of all, thanks to all of you and the folks at home, as well as everyone else who has contributed patients. I think this has been a really great study in terms of enrollment, and the fact that we're a year ahead or more really shows that if you do the right study within the cooperative groups, you can accomplish what you want to do. And hopefully when the study reopens, you will continue to be enthusiastic. And for anybody who doesn't have the study open yet, now might be a good time to think about doing that, because it will probably take a little less than a year for the additional 300 patients to be enrolled. So you could still make a very nice contribution during that period, and potentially one sufficient enough to get an authorship position for the local study principal investigator. So thanks again for everybody's enthusiasm. And of course, we still have a long way to go for the second randomization. but we will have an opportunity to report out some of the information from the first randomization once we have all of the patients past that second randomization. So it may be a few years still, but we will have information for you hopefully soon.
Thank you, Dr. Arlovsky.
Any questions from our audience?
Also, one other topic to mention is that now would be a good time to think about follow-on concepts for maintenance, since it takes about a year to get a new study open through the cooperative groups. If you have an idea about something you'd like to do in this space, now's the time to start socializing it, as it were.
Dr. Arlovsky keeps giving us new ideas and hard work. So if everybody can keep that in mind for the next design. We want to make sure that we can have the best treatment options for our patients. Okay, if no questions, sorry, I'm not able to even see the online questions from this computer here. So, okay, all right, great. Thank you, Sharon. All right, we'll move on to the next study. That will be S2005. And Dr. Alawadi actually is in New York for another meeting, so has the conflict, but Dr. Bhutani will present this study. Dr. Bhutani, would you please go ahead?
Yes, thank you, Dr. Can everybody hear me okay?
Yes, we can. Thank you.
Okay, great. So I'll be presenting this Waldenstrom study that has gone significant changes in the last year or so. So currently it's a phase 2 randomized trial of ibrutinib plus rituximab, which is the current standard of care versus venetoclax and rituximab in newly diagnosed Waldenstrom's patients. Next slide, please. So the previous study, the way it was designed and was approved by the CTAP and all was opened briefly was a concept of IR versus IVR, which was ibrutinib, venetoclax plus rituximab, with a primary outcome of complete response. But unfortunately, there was another trial of IVR, which was a single-arm trial of ibrutinib plus venetoclax open at Dana-Farber, where a few cases of sudden cardiac death was seen. And because of that, at that time, we decided to put the study on hold and had further discussions within SWOG and CTAP. And based on our discussion, then we decided not to move forward with that concept and change it to the current concept of IR versus VR. It is unclear, at this time, we did not know what the reasons for those deaths were, but those were cardiac, and we are not sure, if there was additional, any other reasons that could explain those. Next slide, please. So just to give a little bit of background, the venetoclax, has been studied in a phase 2 trial. This was again done at Dana-Farber Cancer Center, in which a single agent venetoclax was given to patients with the relapsed refractory Waldenstrom's, and shows overall an impressive response rate close to 85% with a VGPR rate of around 19%. Overall was well tolerated, with the main side effect being neutropenia. In this study, there was no evidence of cardiac toxicity. Next slide, please. So this is the current design. Patients who are newly diagnosed will be randomized to IR versus VR, and we are planning to give on both the arms a limited duration of treatment for 24 months. And after that, the patients will be monitored for a total of 5 years. We do allow crossover from both the arms if there is evidence of progression noticed on either arm. Next slide, please. So this is the rationale sort of for the new study design. Mainly, it was for the safety reasons. Secondly, there is no data right now for venetoclax in combination by itself or in combination with rituximab in newly diagnosed patients. So we hope that this will be a good combination. Secondly, the current treatments for Waldenstrom using ibrutinib and BTK inhibitors sort of have tested limited indefinite treatment, and this study will be the first one to test the limited duration of treatment. And the fourth reason is that the BTK inhibitors, although effective, tend to have significant toxicity, especially in older people with cardiac toxicity and arrhythmias. So we think this could be possibly a more effective as well as a safer regimen for those patients. Next slide, please. So these are some of the sort of details of the protocol that I already sort of went over, but primarily sort of, we're going to compare IR versus VR for a limited duration of time of 2 years of treatment. We will allow crossover. We have added more cardiac assessments, and the primary objective had to be changed to VGPR or better. Although in the previous design, our primary objective was complete remission, but we didn't feel that the chances of having a reasonably high number of CR was possible with the doublet regimens. Next slide, please. So the primary objective has been changed to VGPR or better. And the secondary objectives include, complete response, progression-free survival, time to next treatment, duration of response, overall response, safety, as well as overall survival. Next slide. These are the broad inclusion criteria, which are fairly standard for newly diagnosed patients. So patients have to be previously untreated, except they could have received single agent rituximab, but has to complete the treatment more than 12 months in advance of enrolling on this trial. Creatinine clearance of more than 30, and the blood counts with a platelet count of more than 50,000 and hemoglobin more than 8 with the ANC of more than 1. Next slide, please. These are the numbers, we have calculated based on our hypothesis that we will see a VGPR or better rate of around 55% in the VR versus about 25% in the ibrutinib rituximab arm. And based on that, we will need about 66 patients to enroll in the trial. We are hoping to have 2 to 3 patients enrolled per month. So the study will open likely in ECOG, through ECOG as well as Alliance. I think that's all I have. And we are currently, when we went redesign the study, we did go back to SWOG Executive Committee, and we have received approval from them. And currently, the study is back with CTAP, and we're hoping to sort of get the approval, within the next month or so, and then try to reopen the study at the centers. So we hope, everybody will participate, and, hopefully this will be a good study and, have a decent accrual rates.
Yeah, just like a couple of
Happy to take
comments from me. Would like to echo that we hope all of you will be involved. We haven't had a Waldenstrom study in the cooperative group network for a while, and it would be great to have this be a successful one. I don't know if you've had a chance to use venetoclax for Waldenstrom, but I've used it on a few folk, and it has worked really well, and the tolerability has been very good. And I've done this in the relapsed refractory setting. So hopefully it will be even better in the newly diagnosed setting. And with rituximab, of course, everything should be even better with vitamin R.
Vitamin R, I like that. Okay, any input from the audience?
Very good.
Okay, if not.
Thank you, Dr. Orlowski.
Thank you, Dr. Bhutani. If no comments, we will move on to the next study. Is Dr. Manasek online?
Yeah, I haven't heard from her, so I think you're going to be Dr. Manasek today as well, albeit with a slightly different accent.
If I can learn to speak Spanish. All right.
Now, in fairness, if she were here, I would have to have you remember that she's Catalan. She would like to have that distinction be made, so.
I apologize. All right. So this study is the Alliance study EAA-173, which is also known as Deter Smoldering Myeloma study. And this is to utilize CD38 monoclonal antibody daratumumab to enhance the therapeutic effectiveness of the Revlimid in smoldering myeloma space. And this study is led by Dr. Callender and from Alliance, and for high-risk smoldering myeloma patients within 12 months of diagnosis, and patients will be randomized to LAN plus Dex versus LAN Dex plus daratumumab. And depending on the disease response, they can either, after 2 years of treatment, they can be off the treatment or continue the treatment for 2 years. The accruement status as of now, this study was activated in April of 2019, and total planned enrollment was 288 patients. And accrual as of May 4th of this year, 137 patients were enrolled. And this is the site enrollment data based on states. Any comments or feedback from the audience regarding this Deter smoldering myeloma trial?
Again, looks like this is about halfway enrolled, so you still have an opportunity, hopefully, to keep enrolling or open it at your site if it hasn't yet been opened. And also keep in mind to consider other topics to follow on from here. There's already some discussion about a follow-on concept within our group, and now would be a good time to try to work on finalizing that. But certainly this is an attractive study for your patients. I think, as we mentioned at the working group session yesterday, the one challenge I've seen is that patients have to be within 1 year of diagnosis of their smoldering disease. And a few of you may have people who are further out than that, whose numbers are increasing, and they would not be eligible. And we'll try to get that feedback to the folks at ECOG and see if they would consider a protocol change. But really a good study, since either RevDex or Dara RevDex should be able to prolong progression-free survival compared to just observation alone, and hopefully overall survival as well, especially presumably for the triplet.
Sounds great. If no comments, we'll move on to the next study. I know Dr. Gowen is online. Dr. Gowen, would you like to take over?
Good morning. I'm so happy to join you virtually from Tucson, Arizona. I'm really jealous I'm not there with you in San Francisco. Hopefully I can join the fall meeting. So I am presenting just a study update on the EQUATE trial. This is ECOG EAA-181. And this is a picture of beautiful Sedona, Arizona, if you have a chance to visit Arizona. Next slide, please. So the EQUATE trial is a randomized phase 3 trial for newly diagnosed multiple myeloma for our ISS stage 1 or 2 with no intent for early transplantation. Patients are allowed to receive 1 cycle of treatment prior to registration. Patients upon registration will then be receiving a triplet therapy based on Maya data DRD times 9 cycles with subsequent MRD testing and randomization to either a quadruplet with the addition of bortezomib, dara-VRD times 9 cycles, or continuation of the triplet daratumumab, lenalidomide, and dexamethasone times 9 cycles. There is stratification of MRD status and RISS stage. Next slide, please. And then dara-len is continued in maintenance. So just a brief update of where we are with this study. The study was activated in October of 2020. And there have been an intervention 138. This has been slower than we anticipated. We would hope to be a little bit more ahead of the game as far as those that are in intervention, but I do think that we are picking up pace with more in screening. So a plug for all those online. If you have yet to open this trial at your site, consider activation. There is still time. Thank you so much.
Thank you, Dr. Gowan. We apologize to our audience in the room. This display of the slides actually got cut off both at the top and also at the bottom. So that's why when you read it, it looks different from what we see here. From actually online audience, they actually have a better view. All right. Well, hopefully, like we have more sites who can join this. This is a joint effort between all the corporate groups. So hopefully more sites will be joining and enroll more patients for this study. All right, we'll move on to the upcoming studies. We actually have 2 trials in late development stage that will be opening soon, hopefully. So Dr. Alawadi, as I mentioned earlier, he is not available today. So I will, on behalf of the study team, to report to you some of the updates for S2209. So this study we have presented multiple times in the past. This is for our real world patient population, newly diagnosed frail patients, and try to compare the RVD light regimen versus the DARA-RD based on MAIA trial. So I think you probably heard from our team for this background. I will not repeat those. The schema, just to refresh your mind, the RVD light is bortezomib, lenalidomide, and dexamethasone as the induction therapy for a total of 9 cycles, followed by the maintenance therapy with lenalidomide alone, which is listed in arm 1. And for arm 3, which is based on the MAIA trial, induction therapy with daratumumab, lenalidomide, and dexamethasone, which is DRD regimen as the induction therapy for 9 cycles, followed by maintenance therapy with lenalidomide and daratumumab. And arm 2 keeps the same induction therapy as the arm 3, but the same maintenance regimen as arm 1, which is DARA-RD followed by lenalidomide alone. Oops. We do have the risk stratification factors built in, frail versus intermediate fit, as classified by the myeloma frailty score, and also the interface FISH for high risk versus standard risk, and also any myeloma treatment received before registration. Study objectives to compare overall survival in this particular patient population, arm 1 versus arm 3, and also to study the PFS between arm 1 and arm 2. Eligibility criteria, in terms of the diagnostic criteria, pretty standard according to IMWG criteria 2015. A couple of other comments, patients, they are allowed to have short course of the steroids. Local radiation therapy is allowed at least 3 days prior to starting the induction regimen. And patients are allowed to have 1 cycle, up to 1 cycle of induction therapy. However, it has to be non-DARA based regimen. As mentioned earlier, this is for frail population. So if the frailty score is 2 and above, which is frail patients, they can have any degree of the kidney function, and their bone marrow function, if it's a hemoglobin above equal or above 7, platelet count of 50,000, and ANC 750 and above, those patients are allowed. For intermediate fit, which is frailty score 1, only patients having kidney function with a creatinine clearance less than 30, or their hemoglobin between 7 and 8, platelets between 50 to 75,000, and ANC 0.75 to 1, and also revised IS stage 3, those patients will be allowed. This is to differentiate from the EQUATE inclusion criteria so that we don't have 2 studies overlapping. And those 2 regimens are the most commonly used frontline therapies for our frail patient population. It's important to consider that because this is to enroll real-world patient population, which we know that tend to have more elderly or frail patients with more comorbidities. So they might be more sensitive to the treatment side effects, and also the inclusion criteria, because we relaxed some of the hematological or organ functions that may signify a higher disease burden. So this is just to keep in mind. For correlative studies, we will collect bone marrow aspirate, core biopsy, as well as the peripheral blood at the time points of baseline, end of induction, and end of 1 year maintenance therapy. Same time points for imaging PET-CT collection. Actually, we do have imaging sub-study being planned, and I actually just attended their committee meeting at 7 o'clock this morning, and we got a lot of support from the imaging committee, and also great feedbacks. So we are almost ready to submit the capsule form for that. Drug supply, daratumumab subcutaneous version will be provided by the study. All the other agents are commercial sourcing. For this patient population, PRO is very important. We do have 2 instruments built in for assessing the PRO, and Dr. Goen will be leading this part of the study. We do have all the materials, including social media toolkit, to be available on the website. And thanks to Sharon for all these efforts to make this study aware to our patients. And those are the contact information. And we do have the update that we are aiming for May 22nd for the study activation, and we're very excited about this. Happy to hear any comments from the audience. All right. If nothing for now, please feel free to contact us whenever you have, and we have all the contact information here.
So just a couple of comments from me. Hopefully this will be a mostly community site study, given that all of these are standards of care, and the chances are that most of these patients are in those kinds of locations as opposed to larger academic centers. We have a very nice DEI effort and component to this, which hopefully will be successful so that we get a good representation of all kinds of ethnic and other groups within this study. So would really hopefully appreciate your enthusiasm in enrolling. And there also will be involvement from many VA sites across the country to help out. So look forward again to really exciting result with lots of correlative work.
Thank you, Dr. Lasky. All right. So for this study, we actually have sub-studies lined up. And the first one would be this study led by Dr. Calverley. And we would like to invite him for this presentation.
Good morning, everyone. So as Christine was mentioning, this is a planned sub-study in association with S2209, with the patient population being frail and intermediately fit, and the fact that treatment-related side effects might have an increased incidence in this particular patient population. It was just reasonable to consider a sub-study involving a very common side effect of lenalidomide, which is, of course, thromboembolism, and the fact that we need to have preventative strategies in place for thromboembolism in this patient population is important. So what we're looking at here is the efficacy of rivaroxaban, otherwise known as Xarelto, a direct oral anticoagulant, or DOAC, for prevention of thromboembolism in all these patients on lenalidomide associated with S2209. So by way of background, DOACs, direct oral anticoagulants, including rivaroxaban, do provide a potential patient-friendly alternative to current VTE prophylaxis strategies in multiple myeloma. And data on the safety and efficacy of these agents in multiple myeloma is definitely lacking. There are currently 4 venous thromboembolism risk assessment models that exist. There's the IMWG, that's the risk assessment model that's been around now for quite a while. And more recently, there have been 3 other risk assessment models that have come along, and they've all been validated. And one of them is the SAVED model, and the second one is IMPEDE, VTE. And the third one that was just published a few months ago is the PRISM risk assessment model. So again, these are 3 risk assessment models in order to pigeonhole high thrombotic risk patients who are starting lenalidomide for newly diagnosed myeloma, or who are on lenalidomide. So we do know already that the 3 more recent risk assessment models perform with higher predictive and discriminatory power for venous thromboembolism compared with the older IMWG model that was sort of developed by expert consensus. So the primary objective here is to, among S2209 patients, is to determine the incidence of a composite of symptomatic VTE, arterial thromboembolism, MI, stroke, and sudden and unexplained death among patients receiving rivaroxaban prophylaxis for the first 9 months of participation in S2209. So that's basically the induction phase of S2209. And patients who have a baseline thrombotic risk, venous thrombotic risk, in the high risk category, and this includes SAVED 2 or more points and or IMPEDE 4 or more points, those patients will be meet criteria to be able to receive rivaroxaban, and that will be supplied by Janssen. So secondary objectives, to determine among patients receiving rivaroxaban prophylaxis the incidence of major bleeding events and the incidence of clinically relevant non-bleeding events. And this is employing standard criteria put out and used for a long time by ISTH. So of course, that's the other thing. It's we're looking at safety as well here. Thirdly, correlation of the event rate per the baseline SAVED and IMPEDE risk groups. Fourth, the incidence of the bleeding events, major and non-major clinical bleeding per saved LNP risk stratified groups, and the incidence of non-bleeding related complications related to thromboprophylaxis. So this is an observational study. As I mentioned, high-risk patients, either 2 or more by the SAVE criteria, 4 or more points by MP criteria, will undergo prophylaxis with rivaroxaban per the SAVE and MP criteria. The sample size is 123, 98 plus 20% who may be either ineligible or may experience a PFS event prior to the completion of 9 months from the initiation of study treatment. And we anticipate a PFS of 88% at 9 months within the total study population. And as I mentioned, the duration of thromboprophylaxis is 9 months, which is the induction phase duration. And as far as statistics goes, historically, looking back at 2 NCTN studies, the historical rates of 12 to 13% exist for thrombotic events associated with 2 other strategies for preventing thrombosis, aspirin or low molecular weight heparin in newly diagnosed myeloma patients. As I said, looking at S777 and E4A03, we know that the historic rates, thrombosis rates, are 12 to 13%. And because we're dealing here with a frail population, older, frail, we are assuming the thrombosis incidence to be about 1.5 times that 12% rate in among the newly diagnosed myeloma patients. So the observance of 9 or fewer thrombotic events in this trial will be indicative of statistically of VTE events falling below that 18%. So that will be very useful information. It'll be, like I said, it'll be the first trial essentially employing risk assessment models to look prospectively at the incidence of thrombosis in newly diagnosed myeloma patients on immunomodulatory therapy. Okay, so that's all I have to say.
Thank you, David.
Any questions? Okay.
All right, and thanks very much for your perseverance in keeping this concept alive. Turn it back over to Dr. Yee.
Okay, now we'll invite Dr. Hagan to present his study S2213. And I just noticed that our the screen showing all the information right now. Thank you for the technical support at the back.
Okay, thanks. So let's shift gears. So we're going to talk about amyloidosis, so nobody can fall asleep right now, okay? So this is really not my study. I just would really clarify that this has been kind of a labor of love with our group here in SWOG, my co-chairs, Servi and Terry, and all the other cooperative groups, and really including the BMT, CTN, ECOG, and Alliance. So this is a trial that's been in development now, I would say for about 2 years, but probably more formally over the last year. And thankfully, we're kind of getting close to the finish line. So the treatment in amyloid has really moved quickly, and high dose chemotherapy and transplant, the role of that has always been controversial and remains so. So, our hope is that potentially we can answer that question more definitively with this study. So just really briefly, some background. There's really only been one study that ever formally looked at high dose chemotherapy with melphalan and transplant. That was the French study published nearly 20 years ago. And they compared melphalan to melphalan. So at that time, that was really the only treatments we had for amyloid. So at the time, it wasn't a bad study design, but had very high transplant-related mortality that we just don't see these days. So these days we see TRMs down in the 2 to 5% range, which is higher than myeloma, but that's very low and acceptable in this patient cohort. And this is even at smaller sites. So there's national data and single institution data that supports if you choose the right patient to transplant amyloid, you can get them through the therapy safely. The CIB-MTR data shows that we're doing still about 250 to 300 transplant annually for amyloid, and this thankfully hasn't changed even in the era of DARA-VCD. There is about 10% of newly diagnosed amyloid patients are transplant eligible and move forward with transplant. There's some referral data that says that maybe that's higher, 20 to 30% at certain centers, but I think nationally that's about what we see, and that's why the numbers are pretty consistent. Induction therapy prior to transplant is becoming a standard of care. So, I can't remember the last time a patient was referred to me that hadn't had some therapy before transplant. So, and there's data that supports that as well. And I think importantly, this bullet point here, oh, the laser works, there's a really big practice pattern between the US and Europe. So we definitely transplant more patients in the United States compared to Europe. The Alchemy study, which was a big registry study, showed that only about 3% of patients on that registration actually move forward with transplant. So again, different practice patterns. One may not be better than the other, but again, the reason this question is, I think, pertinent. And then although there's a history of some challenge enrolling patients in amyloid to trials, recently the Andromeda trial and actually our isatuximab trial, I think really has shown that there's an increased appetite to really answer some of these questions in this disease. So the primary objective of this study, and I'll go through the treatment scheme in a second, is to compare the major organ progression or the MOD PFS between patients who are randomized to transplant or randomized to continue DARA-VCD consolidation after standard 3 cycles of DARA-VCD induction. This is a composite endpoint that was developed on the Andromeda study. And in amyloid, it's critically important because unlike in myeloma or Waldenstrom's or some of our other plasma cell disorders, we can see good hematological responses in organ progression, and that really impairs patients' quality of life. So renal, cardiac, and hematological progression, as well as overall survival, makes up this endpoint. It also gives an opportunity, again, in a rare disease to study a meaningful outpoint with more events, so we can actually do a trial on this scale. So that's the primary objective. Obviously, there's a bunch of important secondary objectives: quality of life, survival. Individually, we're looking at cardiac and renal responses. We're looking at, I think, MRD in the bone marrow as well as in the peripheral blood. I'll talk a little bit about that. Treatment-related mortality, both on the transplant and the non-transplant arm, because anybody knows, even amyloid patients who don't take the transplant, they can unfortunately have early progression and outcomes and can unfortunately pass from their non-transplant therapy as well. So these are all important secondary endpoints on the trial. Here's the study schema. So patients with newly diagnosed amyloidosis would be registered to the study if they meet inclusion criteria. They would undergo 3 cycles of standard DARA-VCD induction. This is per the Andromeda trial. After they finish that, they would be randomized in a 1-to-1 fashion to essentially consider to continue the same therapy for 3 more cycles, or to go on to consolidative high-dose chemotherapy with melphalan and autologous transplant. Full dose melphalan would be generally recommended, but could be dose reduced based on standard criteria and institutional practices. So, and then after consolidation, all patients would go on to continue 18 months of daratumumab maintenance, again, kind of per the Andromeda approach, but that would be the both arms, transplant and non-transplant arm here. So here are the eligibility are pretty important on this trial. So, and that we've had a lot of discussions, but, essentially these are standard transplant eligibility at diagnosis. And a lot of this data comes from the Boston and Mayo group, but this is pretty standard, standardly practiced, I think, across the country. So patients would obviously have to be eligible for transplant, age less than 70. They have to have biopsy-proven amyloidosis. They have to have trackable disease, so a monoclonal protein in the serum or in the urine or in the bone marrow. They do have to have measurable disease, so a difference in their free light chain greater than 2. And again, that's something we discussed a lot, but there's really no validated data for how you measure responses in patients with less disease than that circulating in terms of their light chain burden. They'd have to have an ECOG less than or equal to 2. Blood pressure, so supine blood pressure greater than 90, and then non-severe cardiac AL based on their cardiac markers. Again, these are kind of standard criteria in the transplant literature. And then some standard organ progression. I think importantly, they have to have a creatinine clearance greater than 30, because a lot of those patients with worse renal function actually have deterioration of their kidney function during the transplant period. So those are patients who are a little hesitant to transplant. No uncontrolled infections. And then after some feedback from both the NCI and CCHEP, we had originally allowed 1 cycle of kind of protocol-driven therapy, but now we're allowing up to one cycle essentially of investigator choice therapy prior to enrollment on the trial. And again, for rare disease, we felt like that was very important. So after they undergo their induction therapy and they're going on to randomization, importantly, they still have to be eligible for transplant at that time. Like I mentioned, even with standard therapy, we can have some deterioration clinically. Hopefully that's a small proportion of patients, and I'll get to that in a minute. And then really the only unique additional criteria would they have to have at least a partial response to that in 3 cycles of induction. Because if you're not responding to 3 cycles of DARA-VCD, you're probably not going to respond to 3 more cycles. So those patients would be ineligible. That's going to make up a very small cohort, less than 5% of patients if you look at the Andromeda data. And then I guess the only other important thing that I didn't put in red is afterwards, they have to be actually able to collect enough stem cells to move forward with their transplant. So here's our methodology. Again, there's our experimental arm, which is the high-dose chemotherapy is being compared to the DARA-VCD. We're assuming based on the published Andromeda study and the literature to date, a MOD PFS of about 31 months in the DARA-VCD arm versus 50 months in the transplant arm. This is going to be a 2-arm trial they will need 143 participants per arm to actually go through the trial. We're looking at accrual about 29 patients per arm over 5 years with 3 years of follow-up. So again, this would correspond to an increase from about 31 to 50 months in the MOD PFS primary endpoints. Again, the final analysis would be done after 192 events have occurred, but no later than 4 years after the last patient was accrued. So we're anticipating about a 15% dropout due to, again, rarely less than a partial response to induction. And then you do get some attrition and non-transplant eligibility after your 3 cycles of induction. So there is going to be some dropout, and that's kind of, I think, well published in amyloid literature. So this is our estimate on this trial. So ultimately, we'll need to put 159 patients per arm to get our 143 eligible participants to undergo randomization. We had a lot of discussions about stratification factors. Ultimately, these were the 3 that we were able to do statistically and we felt were the clinically most significant. So they're going to be stratified based on the European modification of the 2004 staging criteria, which I think really importantly captures cardiac involvement. And then hematological response after that should be 3 cycles, 3 cycles of DARA-VCD induction, PR versus VGPR are better because we know that patients who get into at least the VGPR have much improved long-term outcomes. And then by the T1114 translocation, because there is some data that high-dose chemotherapy is more beneficial in those patients. I think really importantly, this is a rare disease where we don't have a lot of data. So the translational sub-studies on this trial, as well as the PRO sub-study, I think are critically important. We know that achieving deep hematological responses in the urine and the serum and amyloid does translate to prolonged overall survival and improved organ responses. There's increased data on several MRD methodologies in amyloid, but most is actually based on the next-gen flow assays. There is some clonoSEQ data, but it gets a little bit harder in amyloid tracking that. So we'll be looking at a next-gen flow-based MRD assays in the bone marrow. We know, importantly, that even, again, patients who get into CRs can still have organ progression. So we're hopeful that maybe it might be those patients who achieve even deeper bone marrow responses that will have the prolonged organ responses that we hope to achieve in these patients. So in addition, we'll be looking at mass spec-based peripheral blood assays every 3 months in all patients in at least the VGPR. There's an increasing amount of data that is, I think, really showing that achieving kind of that mass spec negativity in the peripheral blood may translate to equally improved long-term outcomes. So we'll be actually doing that as a later amendment, but we'll be collecting specimens every 3 months so we can look at that potentially. And it actually will give us an opportunity to potentially look at some other studies in the long term. So again, and I think also importantly, because there is some growing literature on both the peripheral blood and the bone marrow assays in amyloid, we'll actually potentially be able to compare the two to see, does a peripheral blood mass spec assay correlate with what we see in the bone marrow? And that might offer patients a unique opportunity to avoid potentially getting bone marrow biopsies in the future to assess their disease status. So I think this is, some really, unique opportunities that we'll be able to look at with the translational studies here. So our primary translational endpoint will be looking at MRD negativity rates in the bone marrow, again, based on next-gen flow, post-consolidation. I won't go through all the secondary and exploratory endpoints, but essentially we'll be looking at sustained MRD negativities using both assays, the bone marrow and the peripheral blood, and then again, kind of comparing the two to each other over time in these patients. Lastly, but definitely not leastly, we are looking at, we have a formal PRO study that's built into the trial. So, if the trial does not meet its primary endpoint and the outcomes are clinically similar between the two approaches, quality of life of the approach may actually be important in a decision-making tool for these patients and their clinicians. So we'll be using the PROMIS 29+2. The PROMIS has been validated in AL, and there's just a few additional quality of life assessments we'll be doing in addition to the standard PROMIS assay. And again, a lot of additional kind of secondary and exploratory endpoints that we'll be looking at here. So we are in a tight timeline on the study. It's been formally endorsed by the BMT CTN back in October, and I'll be giving them an update in June. It's been approved by the NCI Steering Committee and formally by the FDA. We've resubmitted to CTEP after their second round of feedback, so we're hopeful we've kind of come to an agreement and can move forward. There were some suggestions that we did make to the protocol, mostly about doing the mass spec studies at a later time period, as opposed to having them formally in the trial now. So we're hopeful we'll get a positive response soon, so we can kind of move forward to the final steps of activation here. I think that's all I had. So now I'll ring a bell. Any questions?
So this will be the first randomized study that we have in AL amyloidosis through the cooperative groups in many years. And so again, would look forward to your strong support and participation so that we can hopefully try to figure out whether transplant is important, yay or nay, and then hopefully develop follow-on concepts after that.
Yeah. Thanks.
Thank you, Dr. Hagen. What if your result is nay for transplant? You'll lose a lot of patients in your transplant clinic. But that's good for the patient.
Good question. Bias, but obviously do with patient. So
Definitely.
I think all those secondary translation studies would be really good. So even if the study's primary endpoint is positive, you'll get a lot of.
Can't hear you.
Oh, yeah, sorry. For those of you making comments here, please speak into the microphone.
Christine was just asking, what if the primary endpoint isn't met? I think that's why all the translational studies and the PROs are critically important to this study. So, we want to do what's best for patients. And, we definitely have a lot more long-term data on transplant than we have on non-transplant approaches. So I think either way, we're going to have a really important study, even if the primary endpoint isn't met. So.
Okay, all right. So we can move on to our other amyloidosis study, actually. This is completed, I think like 1 or 2 years ago. And we will invite Dr. Parker. I believe I saw her online. Dr. Parker?
Thanks. Can you hear me?
Yes, we can. Go ahead,
Okay.
please.
Okay, so super quickly. So S1702 was a phase 2 study of isatuximab for patients with previously treated AL amyloidosis. The first patient was accrued in the summer of 2018. And as previously mentioned, we actually accrued quite well to this study with 43 patients through September of 2019. Next slide, please. So we've done 2 presentations from this data so far. The first was September of 2020 at ISA, which was patient characteristics and the preliminary safety data. This was followed by a presentation in December of 2020 at ASH, focusing on the hematological response rate, which was 77%. So we're currently in the process of reviewing and confirming the organ response data for manuscript preparation and publication. And that is all I have. So thank you.
Thank you, Dr. Parker. Hopefully we'll see the manuscript soon. All right, we'll move on to the concept in development. I think we have one exciting study for high-risk multiple myeloma. Dr. Lipey, are you online?
Yep, I'm here.
Yep, I think I saw you online. Would you like to take over, please?
Yeah, great. So as everyone knows, we've been talking about a high-risk trial, a patient for newly diagnosed myeloma patients with high-risk disease for quite some years. And so this is the most recent iteration of how we are planning to approach this topic. Next slide, please. So, I mean, as we know and have talked about, myeloma remains incurable, and these high-risk patients tend to do worse than our standard risk patients. And with all these new agents that we have coming out, we need to start asking the question about how best to treat these patients and if some of our new medications can be used in accomplishing our goals. So the hypothesis here with this study is that can we add a novel bispecific antibody to our standard of care induction and maintenance and see if we can do better for these high-risk patients? Next slide, please. So here is the most recent iteration of our schema. So patients with newly diagnosed multiple myeloma are allowed to enroll if they've had one prior cycle. They will be randomized to either RVD plus daratumumab versus RVD Daratec. So this induction therapy will be given for 12 cycles, and then they will move on to maintenance. At the end of their 12 cycles, they will have an MRD assessment. They will move on to their maintenance arms, which will be RV Daratec versus RV Dara, and they will have another MRD assessment done at 18 months. And those patients who are MRD negative at both the 12 and the 18-month timeframe will be able to move on to the lenalidomide and bortezomib maintenance alone. Next slide, please. So the objective here is to compare the overall survival between standard of care, which is VRD Dara versus VRD Daratec. And then our secondary objectives are to compare the progression-free survival between these two arms. We are also looking at the overall response rates between the two arms and looking at toxicities. We're going to look at the rate of MRD negativity by next-gen sequencing with clonoSEQ after 12 and 18 months of induction. We're also going to look at 2 and 3 years in those patients who've achieved a very good partial remission so that we can see not only what's happening at the time where we put them onto maintenance, but what's happening after they're onto maintenance and look at their changes over time. We're going to look at the progression-free and overall survival between those patients who achieve MRD negativity and don't. And we're going to look at the progression-free and overall survival amongst those patients who are MRD on the intensive arm versus the maintenance arm. So we're going to compare all of those different possibilities. And then we also have an analysis of patient-reported outcomes in this study. So we're going to look at how these individual regimens impact quality of life and patient satisfaction and preference. And that part of the trial is being led by Christina Gowan. Next slide, please. So as mentioned, this is for high-risk study patients. So they need to have sort of their CRAB criteria to meet the diagnosis criteria for multiple myeloma and have measurable disease. Next slide, please. So we're defining high risk pretty strictly for this trial, which is a little different from the last trial, but it's going to be patients who are high risk or stage 3 by the revised ISS staging criteria, but we're also looking at the R2 ISS staging criteria and allowing those patients who are high risk by the R2 ISS to enroll in this trial. This trial is not for non-secretory patients or for patients with plasma cell leukemia or patients with known amyloidosis. Next slide, please. So this is how we're going to work the cycles and the doses that we're going to give. So the RVD DARA is going to be on a 28-day cycle with weekly bortezomib, lenalidomide, and dexamethasone, and the daratumumab will be per standard prescription. The teclistamab will be added as well, but with the RVD DARA tech arm, the dexamethasone will be dropped after cycle 1. Next slide, please. In maintenance, the RV maintenance will look as bortezomib every other week with a reduced dose of lenalidomide. Patients on the RV DARA arm will continue their daratumumab monthly, and those on the RV DARA tech arm will also add in the teclistamab, which will be given on days 1 and 15. Another caveat with this trial is that stem cell collection is allowed. So while these patients are not planned for an upfront induction, stem cells can be collected after 4 to 6 cycles so that those will be available for when patients relapse. Next slide, please. So the stats for this trial, we're looking to enroll 210 patients, a total of 232 patients, and we're hoping that 210 of those will be eligible. We're hoping for about 35 patients per year. This is based on how we enrolled to S1211. If this goes according to plan, we'll look at about 8 years to complete the trial, and we'll have an 81% power to detect the difference in those two arms at overall survival if we're looking at hoping for 5 versus 8.75 years in the experimental arm. One of the things that we were hoping to, or I was hoping to get a little bit of feedback from this group is if we're doing this through SWOG, what is the capacity of a community site for a trial like this? How is that working? And how quickly do you expect that to change so that we have an idea of how this will affect our sample size and how well we can enroll patients? So maybe that's something someone can give me any thoughts on at the end here, but I think this might be the last slide. Next slide, please. I think, yeah, that's the end. So I don't know if anyone has any thoughts about the trial in general or specifically on, what this means for community sites with this type of an agent.
And there was a discussion yesterday at the working group about teclistamab and whether it was feasible for community sites to be able to deliver that and whether it would have to be a partnership with a local academic center where the tech could be given at the academic center for cycle 1, and then patients could be transitioned back to the community starting with cycle 2 once the risk of CRS and ICANS is fairly low. I think that was the major point yesterday, and if you all have any comments, that would be appreciated. Okay. If not, just also to let you know that although these are probably not yet ready for presentation here, but hopefully will be ready in time for the fall meeting, there is work going on for a study on renal amyloidosis with one of the antifibril antibodies, which we're polishing up and hopefully will be ready for next time. And there also is discussion about a maintenance follow-on study looking at perhaps withdrawing or even considering not giving maintenance to some of the best risk patients. But there is room, as you've heard throughout the presentation, for those of you that have ideas to bring them forward, which hopefully could lead to future studies. Jack, go ahead. Looks like you have a comment.
I just had a question of clarification. I've seen this schema and the tech arm sometimes include DEX and sometimes not include DEX. Which is it?
Brea, are you still on?
She's on inpatient service. Maybe she
Gotcha.
already logged off. Sorry.
Yeah, there is a small DEX pre-med in the first cycle, but after that, the hope is to get rid of it altogether, predominantly to reduce any T-cell toxicity, but also as a nice bonus to reduce DEX-mediated effects on patients as well. Yes, sir. Could you please come up to the microphone?
Just a technical question. Previously, I think this study had a number. It was S1911. Was that withdrawn or is it going to change?
I would think the number will be updated to something like
Okay.
22 whatever or 23 whatever.
Okay.
Yeah,
Okay.
thank you.
Thank you.
Hopefully it'll be an auspicious number.
So for the FISH criteria of high risk, is it based on CD138 enriched plasma cells? And do you have any requirement for the cutoff of, say, P53 or translocations?
So that is something that we haven't prescribed. Sorry, I had to switch computers. But that is something that we haven't prescribed at this time, but we're just basing it on the IMWG criteria for stage.
So I think the local fish is probably what's going to be used. And so there will be some differences in practice patterns where some places will probably do 138 purification, which I would certainly agree would be considered optimal, but there may be places that either don't do it locally and send it to a central lab that doesn't do it, or that do it locally but don't purify. And unfortunately, we may miss a few patients as a result of that. All righty. Any other topics that folks wanted to bring up? If not, thanks very much for your attendance and enthusiasm, and enjoy the rest of your meeting here at
Dr. Lasky.
SWOG and San Francisco, unless Dr. Yee has something else.
I raised my hand, but you did not see me.
I'm sorry.
Before we conclude.
We
the
all
meeting-
have our blind spots.
Fortunately, we're not driving. Before we conclude the meeting, I would like to thank all the studies, like from our teamwork. Dr. Rich Little from CTAP, thank you so much for all the constructive and critical comments to all the study development. To our stats team, our chief statistician, president of CRAB, Anji, thank you so much. And also Rachel, Adam, yes. And also operational team, Sharon, our project manager, Hannah, if I forget anybody. Dr. Lasky, maybe you know anybody else that we need to thank all these joint efforts.
No, thank you for all of you and for bringing up the kudos to everybody. I think this has been an exciting committee to be a part of the last few years. And also thanks to Jack for his invaluable input on all of these studies, which really helps them to be a lot more patient friendly.
Yes, appreciate everybody's effort. Thank you so much.
All right, thanks everyone.